Good morning, everyone. Here is a patient, a 28-year male, an engineer, a resident of Mumbai, has presented to us with pain in the groin, reduced movements in both hips, and difficulty in walking since 1.5 years.
Pain in both the groins?
Yes, sir. Pain in both groins, reduced movements in the both hip joints, and difficulty in walking since 1.5 years.
Is this patient's complaint, or you have?
The patient is complaining specifically about reduced movements of the hip.
Reduced movements.
Yes.
Since when?
Since 1.5 years.
Restriction of movements. Better word.
Restriction. Yes. Restriction of movements. The patient was apparently all right 1.5 years back when he developed pain in a right hip, which was insidious in onset, gradually progressive, which was dull aching type, which was waxing and waning, and which was aggravating on walking, and which increased in the early morning, which reduced on activities.
1 minute. So, in between the attacks of pain, there was a complete remission?
No, sir. There was a period of reduced pain and the period of aggravated pains.
But some pain would remain at rest as well?
Yes, sir. Initially, there was no rest pain. Gradually, it increased to rest pain also. Patient also complains of restriction of movements. Initially, he was having difficulty in squatting and difficulty in sitting cross-legged. Now the patient complains of inability to stand with both feet together. The patient also complains of difficulty in walking, which was insidious in onset, gradually progressive. Initially, he was able to walk unassisted for about 500 meters. Then he had to take rest because of pain. Now, which progressed to a stage where he could not walk unassisted. So the patient is walking with an assistance of elbow crutch on right hand, with the pain on every step. And now the patient is presenting with inability to walk even for a small distance.
Even with the aid, patient is not able to walk?
Yes, yes, sir. Since 15 days, he has an exaggerated pain. Even on walking for 2 to 3 steps, he gets severe pain.
So you tell wheelchair bound or bedridden like that. You don't have to describe so much, even 2 steps, 3 steps.
Community ambulator,
Inside a
household
room.
ambulator with the support.
Wheelchair.
Or
Sir, he is wheelchair bound, but
bedridden.
for toilet facility, toilet and all, he walks.
Don't worry about that. There is a wheelchair bound.
Wheelchair.
Okay. With so much of a keeps able to stand, and don't tell that is there. So it's a wheelchair bound now.
For the above, the patient also has a history of stiffness in the back and in the large joints, mainly in the lower limb, in both hips and both knees, which was insidious in onset, gradually progressive. Initially, the stiffness was there for minutes, which reduced on activities. Now that has progressed to hours. The stiffness will be there for 2 to 3 hours, and it reduces on activities and reduces on taking hot water bath, which does not reduce on rest. For the above complaints, the patient visited a government hospital 1 year back, where oral medication on a daily basis was given with a regular follow-up. But the patient, the symptoms got worsened even with the medications. So the patient presented to us with current disability of inability to walk unassisted, sit cross-legged, and squatting.
See, all these things you may not describe so much in detail. Patient had taken symptomatic treatment, but without any much of relief. That's all. So that understands whatever you described, all those things, medications, he was taking regular follow-up, he was then, but then again like this. So
1.5 years.
1.5 years. He has taken symptomatic treatment.
And
only.
in are other joints also affected?
Yes, sir.
Upper limb joints
yes,
are
sir.
affected. Which joints
The
are
pain-
affected? That
The
also we should-
pain started in the left hip. Similar pain after a few days. Similar pain he got in left hip and both knee also.
Was there any back pain associated?
There was no back pain.
Was it associated with knee pain, small joint,
Knee
foot
pains
and
are
knee
there, no.
affection of the joints?
I was coming to that.
Pardon me?
I'm coming to the next. I was telling.
That you should combine. No?
Combine.
We thought that you were already at the end of the history. No?
History, yeah.
No, sir. I'm
You're
continuing.
not at.
See, I told you now, onset, progress, end result. You are now end result that he has taken treatment and there is no relief. That means it ends your history. So you should have told other joint affection beforehand.
What is your probable diagnosis with this history? What are you thinking in terms of?
With no history. Should I complete?
history.
Now that you've got this history, what are you thinking in
What
terms
is the
of?
thinking process as regards the diagnosis?
Sir, this polyarthalgia secondary to inflammatory etiology.
Arthalgia or arthritis?
Arthritis secondary to inflammatory etiology.
Like
Sir,
Inflammatory.
seronegative spondyloarthropathy and rheumatoid arthritis.
what are the features in favor of rheumatoid arthritis? What are the features in favor
So
of?
what basically now you're thinking in terms of an inflammatory
Inflammatory.
arthropathy, whether it is seropositive rheumatoid group or seronegative Ank Spon.
Yes.
Okay, considering what is a male young patient, what are you more likely to be? Yeah, so you have to give us history that is going to support
Yes.
that, and as sir said, any history which gives you negative about rheumatoid. So does he have small joint affection? Which was sort of, was it symmetrical? How long has that joint been affection been? So that all history should come rather than wasting time about how much it is. So your history has to be very precise.
If you are thinking in terms of seronegative spondyloarthropathy, then what are the contributory or what are the specific leading specific questions that you would ask?
Sir, is there any
Positive or negative, whatever.
sir, is there any symmetrical or asymmetrical involvement of the joints? Is there any
For
involvement of,
seronegative, what will you ask?
is there any visual symptoms? Is there any bowel and bladder symptoms?
Bowel and bladder symptoms. That occurs in which condition?
Sir, in bowel symptoms, mainly enteropathic arthritis, mainly because of inflammatory bowel diseases,
Okay.
and
Reiter's
bladder
syndrome?
mainly reactive arthritis.
What is Reiter's syndrome?
Reiter syndrome is a urethritis and uveitis or iritis with arthritis, asymmetrical arthritis.
So what is this family of what are the family of seronegative spondyloarthritis? Can you just enumerate?
Ankylosing spondylitis,
Tell the other family members of that
ankylosing spondylitis, psoriatic arthritis,
Psoriatic arthritis, very good. Then
reactive arthritis,
reactive
enteropathic arthropathy, juvenile idiopathic arthritis.
juvenile idiopathic is not. Then
Ju-
any Behcet syndrome? What is Behcet syndrome? Yes, anybody? Reuters, you said, no?
Yes, Reiter.
Sorry. Then
So then now your history has to proceed according to this. Most likely Ank Spon. So what will you ask for Ank Spon?
watering of the eyes, loss of vision. When do you get that? Ulcerations here, mucosal ulcerations, diarrhea,
Ulcerative?
ulcerative colitis.
Ulcerative colitis. So the 5 things you want, no? Ank Spon, ulcerative colitis,
plaques,
whether
vision, silvery
Reiter's or
scales on the skin.
you have a
So it is so you understand. We understand. Then any urethritis, not bladder, urethritis, burning micturition.
Burning
and then
micturition of blood.
This
What are collagen disorders? Collagen disorders, and they are seropositive or seronegative?
Seronegative.
Collagen disorders are seronegative. Anyone in the audience, what are collagen disorders? Anyone?
All the Sjogren's and SLE and other.
Yes, Sana. Collagen disorder क्या होता है?
SLE, connective tissue disorder.
Connective tissue.
Scleroderma.
Very good. What is pannus?
It is it is the inflammatory reaction formed by the synovium of the joint.
How does it
which is,
look like under microscope?
inflammatory.
Why the word pannus?
There will be granulation tissue which is surrounded by multinuclear giant cells.
Okay, we come back here to the history now. So you have to tell us. So that history is now your history is fragmented and not in a smooth flow. You understand what I'm saying?
Yes, sir.
So in the hip also there you can mention there are other joints also. You cannot tell if you have missed now tell us now what other joints. What are the you can continue with the
Sir,
history. What
the patient
where have you left?
yes sir, there is no history of limping in the childhood. There is no history of trauma. There is no history of fever, loss of appetite, weight loss, or evening
Positive
rising
history
temperature.
tell us. Any other joints, any positive history of other joint pains?
Pain in the both knees.
That you should mention. No? Is it
There is no history of other joint tenderness or hand involvement or any other small joint involvement.
okay?
And there is no history of visual symptoms or urinary symptoms or bowel disturbed bowel habits. There is no history of
Skin lesions.
there is no history of skin lesions.
Any personal history contributory?
Patient had a history of alcohol intake for 2 years and tobacco chewing for 5 years, which he abstained after a history which is suggestive of ascitic tap, which was done 2 years ago. That's all. There is no significant family history.
This fellow is chronic alcoholic. No? He interpreted it as ascitic acid. He is a chronic.
History was suggestive.
Okay, so he is a chronic alcoholic.
Chronic.
And along with that smoking. Then now at the history now where are we?
Bilateral hip arthritis, secondary to inflammatory secondary to
Why can't
inflammatory
it be avascular necrosis, bilateral avascular necrosis? Why can't it be this?
sir,
It's only hip involvement, no other joint involvement.
sir, he
Back
also
you
completed-
said, back you did not mention anything. About the back,
yes,
you did not mention anything about the back.
sir, the stiffness in the back is there, sir.
Is there?
Yes, sir. Morning stiffness is severe for him, which
How long is the morning stiffness
this is
lasting?
that is going for hours, 2 to 3
More
3
than
hours.
half an hour.
More than half.
So that is that cutoff point. Okay. So still we are not certain.
We're not certain, but
So it's a differential at the end of the in the history you would have two differential perhaps. One is seronegative
and
and other is it can still be avian.
still be
Avascular is a chronic alcoholic and he has a recent episode, some episode of acute abdomen, right? Backache with the acute abdomen. Yes.
continue with examination.
Hmm.
I have examined the patient in standing, sitting, and
Patient is unable to stand. How did you examine?
You don't like a protocol.
There you are cut.
Sir,
You just said no.
the patient can stand, sir. He cannot walk on his
Make him stand. Now, what is the lie of the patient in lying down position? How is the attitude of the
flexion
patient?
attitude. Flexion of hip and knee.
Huh?
Flexion of hip and knee, sir.
And
He will never give.
flexion and
With the next.
huh?
जरा करके दिखा.
Make him his attitude is what?
Flexion of hip and knee.
And as regard adduction abduction, how is it like?
That is abducted bilateral.
Do you think looking
stands with
looking
the-
at the patient's attitude, I don't think that he will be able to stand.
Yes, examined.
Yes, sir.
Take out his shirt.
उसको जरूरत नहीं. खड़े हो जाओ. He
We
can
can
stand.
take out his
Shirt.
take out shirt so that we can appreciate it. Arvind, this fast say help him out. So now, how is you describe him in standing now?
Sir, the patient stands with bilateral shoulder at the same level with from the front, the anterior right anterior
Wait,
superior iliac spine.
This I am going to tell.
Right anterior superior iliac spine is at a lower level than the left.
Lumbar spine. How is the lumbar spine? Where is the? Is there any bending?
Yes, sir.
Shoulder के बाद में एकदम directly you come in between is the spine, no?
Sir, from front I was telling, sir. The bilateral shoulders level are at the same level with the right anterior superior iliac spine is at a lower level than the left with bilateral patella and medial malleolus at the same level with abducted both bilateral limbs abducted while standing with there is increased lumbar lordosis with loss of balance, loss of sagittal balance with head anterior to the level of pelvis.
He'll fall, no? ऐसा मत बोल रहे. Don't loss of surgery. Don't.
The head is anterior to the pelvis.
There is an increased lumbar lordosis. Is there any bending? Is the coronal plane? How is the lumbar spine compensating?
If there is increased lumbar lordosis.
That is the sagittal plane. In the coronal plane, there is a deformity, no?
Yes.
So will there be a compensated deformity on the lumbar spine?
Yes.
Compensated deformity will be there.
Yes, sir. There will be
Is there or is there no scoliosis?
scoliosis with the convexity on the right side.
So that
See, in like SLR in the last case, here don't talk about those sagittal balance, all those things. Otherwise, people will think it is a spine case. Okay, so just increase lumbar lordosis. That is good enough for a hip case. So you have to be little, tactful, while presenting this kind of case.
With there is wasting of right thigh and right calf compared to the left side. There is no gluteal.
He's able to walk with support.
Able to walk with
Then
support.
you should not tell wheelchair bound. He's able to walk with support.
Yes, sir, walk with support. That's why.
If you give a walker, he will walk better.
How is he walking?
Yeah.
Bipedal assisted gait with wide based gait with lurching on every step with antalgic component.
Fantastic.
Wait.
He can walk better with a walker. And
Yes,
both the hands.
with an assistance.
Yeah. So you can tell that while telling history, you tell that is able to walk with the support
Assistance of
assisted.
Patient lies down with an attitude of flexion at both hips and both knees with which is more on right side compared to the left side with external rotation of left lower limb with patella facing outwards and upwards.
So in this bilateral cases, this is always confusing that whether to present both the things same time or present one side then the other side.
See, it is a difficult case. We have kept this deliberately because you can get such a case where there is a bilateral involvement. Where there is a bilateral, there can be similar deformity, and yet there is a pelvic obliquity. So these combinations can be there. So you will have thought over this before the exam. Otherwise, you are caught unaware. Yeah, go on.
And in these difficult cases, you score better if you just tell your findings. Okay. So first, it is better to present first one hip, then the other hip. Tell that first finding of the right hip.
I would like to mention about right hip first, then the left hip.
Rather than left right like that, left 30, there 20 degrees like this. If you present both the hips together, it becomes little confusing.
Now you go on. Fine. Don't manipulate. Don't tell us now. Inspection. In lying down in supine position. Chalo.
So, supine position, the patient lies down with a flexion attitude with flexion at both hips and knees, with left lower limb slightly external rotated, with patella facing upwards and outwards.
You have to describe this limb appears to be in a lie. This limb appears to be
There-
more flexion than
more-
the other limb. Then go on.
Yes, sir.
Anterior
The-
superior iliac spine and other things. No?
The anterior superior iliac spine is at a lower level as compared to the left side.
Which side?
Right side is low,
lower
right
level.
side at
No.
lower level compared to the left
This
side.
I'm going to. So now what is the inference?
The-
Lower
there is-
level means what is possible?
There may be more abduction deformity at right hip.
But that does not mean that there is an adduction.
Adduction deformity at the left.
It's a tricky thing. That's why. In this particular case, not usually.
Yes.
Usually, the ASI is at a higher level means that side is there is an adduction deformity. But we'll go on now.
There is no local rise of temperature. There is tenderness present. There is rise of temperature over left greater trochanteric area with diffuse swelling over the great trochanteric area, which is tender.
Superficial tenderness is there.
Superficial tenderness is present over the left greater trochanteric.
What is that due to? Possibly.
Possibly due to, sir, can be bursitis, can be enthesitis also.
Bursitis. Enthesitis. Okay. What is enthesitis? Since you have
It's
uttered that term.
It is an inflammation of an area where the tendon attaches to the bone.
Ligament attachment.
Spine, how do you get it? Enthesitis in the spine also, no? So
Yes, sir,
ligaments.
in the spine, ligament.
Okay. Then
There are no scars or sinuses.
you have come to palpation, no? Huh?
Yes.
Huh. Anteriorly tenderness, anteriorly, laterally.
The tenderness is present on anterior joint line of both hips, and there is no superficial tenderness over left greater trochanteric area, whereas deep tenderness is present over the left greater trochanteric area.
Which hip are you presenting?
Right.
just now?
Present now.
So, see, Dr. Mohanty has said stick to one hip
One
first, because
first.
otherwise you are going to go in between it. You're going to confuse us. You're going to confuse yourself. So first present the findings of the right hip,
Right hip.
complete, then we go to the left hip.
There is tenderness present over the anterior joint line of the right hip. With there is no superficial tenderness over the greater trochanter, but there is deep tenderness present over the right greater trochanter.
Don't stop. You continue. You should not
As
stop.
I could not square the pelvis, I took the line between the bilateral anterior superior.
Suppose there is a patient with bilateral hip flexion deformity. First, describe how would you like to assess individual flexion deformity, and then
for that, because I cannot.
you cannot. There is no mechanism by which you can find out FFD on the right side and FFD on the left side. You can. You describe. You may not do it if the patient is painful.
Now we are tracing the range of movement.
No, sir.
Or we are still at a
Mainly
palpation.
deformity, I am telling, sir.
Deformity.
Yes, sir.
The
Before
deformity will go with the range of movement also.
Yes, sir.
Next is the range of movement.
Yes,
Now, come on, let's discuss only the right hip.
Yes. The flexion deformity of 45 degree in the right hip.
Now this we would like you to show us how did you see flexion, because there is bilateral flexion.
Yes, sir.
How did you check the flexion deformity?
Yes, sir. I'll tell the patient to flex both hips simultaneously. Before that, I'll insinuate the my fingers below the lumbar spine, as the there is no hyperlordosis at
Because flexion is in flexion.
flexion in flexion. So I'll tell the patient to hold the better knee, for better knee, and I'll try to
We
extend.
are testing right hip. Now we will do something on the left hip.
Yes.
Now what do you
I
want
will
to
hold. I will tell the patient to hold the left hip in this to a flexed position.
How much flexion?
Till the lumbar
Number is not there, no?
It's
Now
already
also.
obliterated.
It's already obliterated. What will you obliterate it? Now
So
you have to make it
I will
appear.
hold
No?
Yes.
Make it
Make it
appear.
appear,
no?
yes.
Otherwise will not. For the want of time, now I'm
Yeah,
just. He's
Right hip,
testing
sir.
right
Right
hip.
hip. Yes.
What will you do to the right hip to get the
It is flexed, sir. Also flexed. Both
What
hips.
are you checking now? How much is the FF?
Yes.
So what will you do next?
I will extend the hip after flexing. ये पकड़ो ये. Just पकड़ो.
The question is, how much flexion you will give?
To exactly obliterate the.
It is already obliterated.
It's not
No,
there. No?
first I'll extend and I will make increase the lumbar lordosis. Then I'll start to flex again.
Till
Just-
it appears.
till it appears
till
and-
just appears and then.
Flex it just so that it is the lumbar lordosis disappears.
Disappears.
And
And
ask him to hold it in that position.
hold it at that
And
position.
now you extend the opposite side.
Yes.
Do it now.
रुको, मैं बोलता हूँ.
Please use the mics because on the Zoom meeting they are not able to hear you all.
हाँ, इतने में पकड़ो, इतने में पकड़ो. दोनों हाथ से थोड़ा आगे जाओ. करते में पता है ना? होता है ना? हाँ.
Right.
ठीक है, you can hold.
Yes. Idea is just.
ठीक है. Can you do it? Can you take him to the edge of the bed? Take him to the.
Basically, what are you trying to do? You're trying to get the lumbar lordosis again and okay,
Again
what is
and-
flat?
So simple.
Hold both your legs. You hold him.
Yes.
And then you'll have to see, extend one each at a time and see
Bharat,
when the
I will-
lumbar
I
lordosis
will tell you a
appears
simple
there.
thing. Now take it to the edge of the bed. Let his both the hips hang there.
Sorry. If that is hanging, the pain is too. The hip is very painful for him, so I did not do that test. Because he cannot hang this limb, it has to be supported all the time.
You can support it. No? You can support. Take it. Take
Niche.
You have to assistant now. They'll do it for you.
So, Aram, sir, Aram.
Difficult phase is first year.
Take him there. Take him there.
इंजेक्शन
So support it. एकदम उधर जाओ, बैठ के उधर जाओ.
आराम से जाओ.
आराम के जाओ बस.
हम देखो आप दिला सकते.
Flex it now. Flex the hip. Yeah. Hold it flex.
इसको पिलो में
सीधा से जाओ बेटा.
सीधा सीधा.
हाँ, बस.
देना
बस. Now you test. चल. Ask him to hold both the hips. No? हाँ, चल. वो फ्लेक्स करो दो. परवीन.
सीधा सो जाना.
लॉरेंस अभी लॉरेंस से तैयार मत कर अभी वो फ्लेक्स कर अभी.
हाँ.
फ्लेक्स कर अभी. ऑब्लिटरेटेड लॉरेंस ना. लॉरेंस हो गया ना अभी. Now you obliterated lordosis. हाँ. So now how much is the flexion deformity? Now measure it with the horizontal plane. You understand what I'm saying? ढीला छोड़ो. Okay. And now you try and extend this. The lumbar lordosis is obliterated. It's still obliterated. Okay. So keep it here, and now you extend this. Now it is appearing again. Yeah. So that is the same thing again there. Put it there. Making it hang, it makes it easier, no? Because otherwise you don't know. How much is the deformity now? How much deformity did you get it, and how much is the actual deformity, flexion deformity?
Did everyone in the audience understand the test being demonstrated?
So there are two ways of doing a bilateral hip affection. Either take to the edge of the table, what is on, or one by one. Alternative.
I can do prone.
But
I can
you have to listen.
Prone. Will not do it because it's quite painful.
Painful.
Make it prone. So now obviously it is flat, and then try and Extend it.
I think if
Try and extend it. Yeah.
with a bilateral hip deformity, it's going to be very difficult to get them prone because they're just not going to be straightening out. Okay, the only way is either you take them to the edge of the bed, or the simple way is flex both hips and extend each one at a time and see when the
Just
lordosis
flex and
appears.
lift
When the
both hips.
lordosis just appears,
when
that
it-
is the amount
When
of
it just
pressure.
When
appears,
it
that is
appears, that is
when you have such severe involvement, 5 degrees here and there is not going to make a difference.
how much is
Uh,
how much the
The flexion
much
deformity
of-
in the right hip is 45-degree without any movements in the right hip, with pain on any attempted movements. So suggesting of fibrous ankylose.
further flexion is there?
No, sir.
There is no further flexion.
No
It's
movement.
more
in
than
any-
45. It's around 80 degrees. Not
60, 70 degrees maybe. Okay, and
And it is
okay, so you
fibrous
have
ankylose
FFD of say 60 degrees with no further movements.
in any plane, sir.
Okay, then
No further movements in any plane.
that's fine. You finished flexion. Now go on to the next. No,
abduction,
To the
adduction.
Adduction.
Sir, in any plane there is no movement.
Same, there's
so
no.
there is no fixed deformity in other planes.
There is
Abduction
no
and-
movement in any planes.
But what is the deformity?
Abduction deformity of 20-degree.
Which hip? Right hip.
Right hip. Yes.
Okay.
So how did you do that?
As I could not square the pelvis, I took a line between bilateral ASIS, for which a particular perpendicular, which makes the axis of the pelvis, to which I calculated the movements.
Come again. We are not understood. We are all. Everybody is confused.
Up,
How did you calculate? Is it possible to calculate or it is not?
Sir,
possible?
as
So why aren't
sir,
you
it is
able
very
to?
difficult to calculate exact movements
Why aren't you able to square his pelvis?
because there is extreme pain and there is no movement at the right hip.
No, both the hips are affected,
No,
and
no.
both the hips
Both the
are
hips.
actually.
So is there a fixed scoliosis for him? Is there a fixed pelvic obliquity?
There is a fixed pelvic obliquity, sir.
There is. Did you lift both the legs and try to abduct on the right side?
Yes, sir.
Was it correcting or not correcting?
It corrects with at the movements at the spine, sir.
So there is movements at the spine. So that
Yes.
you are able to correct, no?
Somebody to go from sitting to walking, there has to be movement either at spine or at hip. It cannot be both, cannot be stiff.
So can you lift the both legs and get him into abduction? So this one will adduct, no? Because if it's a fixed adduction on this
Sir,
side.
only 10-degree of adduction movement is present on the left.
Adduction is there.
Yes, sir.
Does he have a fixed adduction deformity or no?
No,
Reduction deformity, how adduction will be there?
No, opposite side.
sir, left side.
So here there is no fixed coronal plane deformity.
My question is, there is the pelvis is tilted.
Yes.
How are you able to measure the deformity? That is the
Sir,
question.
it is very difficult to
Difficult. Possible, not possible.
sir, approximately
Diplomatic answer was
yes, sir. Sir, approximately the axis can be taken as the perpendicular to a line between ASIS.
No, that is what you're devising. What is asking is very simple. While examining for abduction, adduction deformity, is it that you are done in jerk and the patient had a painful spasm? That's why you couldn't do, because you are committing on fibrous ankylosis, which is tough to take. He is able to actually get up, as Dr. Dhar was saying. So is it that there was a severe pain related spasm that you couldn't elicit? You want to say that, or you want to still stick to fibrous ankylosis?
Severe pain.
Can you
he
just
could not-
palpate his ASIS? Palpate the ASIS.
Where is the ASIS on the right side and where is the ASIS on the left side?
I start to palpate from the pubic.
And he will start systematically from soft tissue to the heart. So from pubic tubercle along the inguinal ligament and then first
He's
bony
doing
point
it
of the-
technically absolutely right. Go ahead.
I will palpate and I will palpate the most prominent area, and below I'll palpate deep. The most prominent area would be the anterior superior iliac spine.
Most prominent area of what?
The ilium.
First bony point.
First point.
First bony
prominent
point
area will
after
go into
from-
the crest. The
First
first
point.
bony
First
point
bony
as you
point,
palpate
crest.
along the inguinal
ligament.
ligament is the ASIS. Okay. And this side? और जितना पैर सीधा कर सकता है ना उतना करके रखो दोनों So where are they?
Uh,
Same level?
no, sir.
No?
This is at a lower level compared to that. Yes, sir.
Same level?
Yes, sir.
So now squared?
Yes, sir.
So you said you can't square the pelvis, no?
So the trunk.
It has to move at the trunk, no? Where else will it move?
So
You'll not be able to move the pelvis only if there is fixed between pelvis and the spine. No.
yes, yes, sir.
So what is it? Fibrous ankylosis or you're still on fibrous ankylosis with fixed pelvic obliquity? You committed on that.
No, it's not committed.
How?
Uh,
Yes,
There is no movement at the hip, sir.
So
With attempted pain at the attempted movement.
Right hip.
Right hip.
I thought there was.
So both hips are fibrous ankylosing.
No, sir. Right hips.
Okay. So
But there was no.
left hip,
I don't think that he didn't have any.
muscle spasm. Yeah. There's a lot of muscle. Inflammatory arthritis, muscle spasm. Yeah.
You get such a case which is painful, which is your bad luck on that day, but you be prepared for that. So now, according to Dr. Shane, you move the spine, let the spine go into bending, and then you can square the pelvis.
Yes, sir.
It won't happen if there is a fixed pelvic obliquity. Okay? So whatever position your legs come in, that is the fixed position you have of the hips.
Sir, I had a doubt. If we reduce that, there is a spinal movement. So there is movement, coronal movement at the spine. So the vertical will be gone.
Vertical or what?
The vertical with which we measure movements.
Which
Movements of the hips.
your vertical or virtual vertical you're measuring, no? You're measuring it with respect to the spine.
This doesn't go delete half. The central line is still there.
So you're going to measure that along that.
So we are still at the deformity. At what? How much is the deformity?
Just tell the deformity.
45 degree abduction, 45 degree flexion, and 20 degree abduction in the right hip.
And external rotation?
There is no external rotation.
It is neutral rotation. Okay. Left side?
Left side, there is a flexion deformity of 20 degree.
This is 20?
30.
Left side? Huh?
He keeps
saw
in a
it,
flexion.
huh?
So he keeps in a flexion attitude.
But
He
it's
can
not
extend
able
the
to
hips.
extending lumbar lordosis appears, no? We just saw it, no? How much is the deformity? Almost 60-70 degree deformity. Again, 20 degrees just minimal.
So let's say assume it is 60 flexion. Then adduction, abduction.
Adduction of 10 degree and abduction of 20 degree.
He's in a almost like a frog leg, no? Can you do it from here? Adduction? Yes. Sure. Gently, eh? It's very painful.
थोड़ा एक आता हूँ अंदर.
What are you doing?
10 degree.
Flexion 30 degrees.
Yes. 10 degree and abduction 20 degree.
Abduction 20. You said, see, there is an adduction deformity, no?
No, sir.
There is no deformity?
No, sir.
On the left side, there is no deformity.
Flexion deformity is there.
Adduction,
No,
abduction, there is no deformity.
we are done with the flexion deformities. We are saying 50, 60 either side. Now we are on the coronal plane, whether there is an abduction or adduction deformity. You said there are 20 degree abduction deformity on the right side.
No, sir. Yes.
Right side.
Yes.
On the left side, is there a deformity or no deformity? There's absolutely no deformity. So how do you account for that? You're not able to correct the or square the pelvis then?
There is no deformity, we should be able to square.
If the left hip is moving even up to neutral, why are you not able to square the pelvis?
That was mainly because of the pain. So
Left hip is also painful.
yes, the hip is also painful. So he was not allowing me to.
Rotation.
Rotational deformity.
There is no internal rotation. With external rotation possible up to 20 degrees.
Is there a deformity?
No, sir.
No rotational deformity.
I think he has messed up with the adduction and abduction deformity on the left side. Okay.
So
When you are moving it, when you are moving the thing, you are moving the pelvis. That is not further adduction. Show it gently. Do it gently. Adduction and abduction. Can you square the pelvis? See it's moving. The pelvis is moving, no?
The pelvis is moving.
Pelvis
on
is
that
moving.
side.
That is not a movement at the hip. Adduction.
डॉक्टर ये बाजू ले रहा है ना, पकड़ के मत, ढीला छोड़ो, आराम से लेके बराबर आएगा, ढीला छोड़ो, और ढीला छोड़ो, और
Pelvis is moving.
yes, same level. Sir.
Is there an abduction adduction deformity at all? Is what I'm asking.
The same level, then there is no deformity.
The ankylosed in straight. Other than there being any.
Ankle is in abduction. Ankle is on both sides abduction. Is in abduction, not adduction.
Abduction.
Then you can see from distance also.
So it is due to the muscle spasm that doing that. Actually, there is no deformity around the joint. Okay. In this kind of inflammatory arthritis, okay, there is no deformity, fixed deformity at the joint level, but because of the muscle spasm, he is assuming this position or posture. So gradually you have to take the patient into confidence. So how much it is? Is it 50-60 degree flexion deformity now left hip? Is the lumbar lordosis now increased? Obliterated. Lumbar lordosis obliterated, so it's about say 30 degree of flexion deformity.
That was because of
So from the beginning,
serious stiffness, so he was kept.
so from the beginning, you tell the examiners it is inflammatory arthritis, patient is muscle spasm, but gradually you make it straight. Tell the patient to make it straight like that, gradually, slowly. Okay, which is you have to talk to the patient. Huh? Then it will be your.
Does he now have fixed abduction deformities both sides?
Yes.
Yes. You saw him walk, no?
Yes.
Was it with fixed abduction deformities?
Abduction deformity. You have now gone from adduction deformity to the abduction deformity.
Sir, adduction deformity.
So is out. Now you are saying it is fixed abduction deformity,
Abduction.
both sides.
You said initially there was adduction, no? 20 degrees.
Sir,
on the left side.
10 degree possible.
Possible.
So now
Abduction
you-
deformity, how is it possible?
Now you are saying fixed abduction on both sides.
Mainly, sir, abduction, coronal plane deformity is present in the right hip only, sir. I could appreciate that only.
So again, was that, as Dr. Mohanty was saying, only because of muscle spasm that has been held and there's no actual deformity in the hip? So what I'm asking you is, can you have fixed bilateral abduction deformities? Yes or no? You have seen him walk. You saw him walk, no?
Yes, sir.
If he had a fixed bilateral abduction deformity, how will he walk?
He walks like this.
He walks with a wide base gait. Abduction at the hip.
Possible or not?
Possible, sir.
Tell firmly. Even if it is wrong, tell firmly.
So
The
then,
examiner gets
so if he has a fixed bilateral abduction deformity, shouldn't his ASIs be at the same levels?
Yes, sir.
So one of your findings is wrong, no?
Sir, if there is an abduction deformity more on one side, there can be
There can be what?
So
I think they
these
want
are
us to move
moments.
on.
So these are moments when you realize that your findings are, the examiners are not very happy with them. So there are times when you have to accept. They were not very happy when he said 20-degree flexion deformity. They proved that it was 60-degree bilateral. They were not happy with the adduction and abduction deformities. So these are the times during your exams when you have to stop and accept and move ahead. But then it can actually fall into your own grave, you know.
Okay, so what about the lengthening now?
Now, before that, so examiner asks you, how will you know the true patient is painful, is in spasm? How will you know the true deformity?
Not possible.
You have then you tell that I'll examine the patient under anesthesia to get to know the true deformity, because the muscle spasm will go, or give sufficient analgesics and then examine the patient again. Okay. Like that.
You cannot square the pelvis here, and you cannot keep both the limbs in the identical position. So true length measurement is not possible. You can measure only the apparent limb length. Okay. Now, what is your diagnosis? No? Any other
Sir, and,
examination
there is,
which is remaining?
There is tenderness over a medial joint line of right knee. Also, there is tenderness over right proximal side on medial side, approximately at the insertion of pes anserinus. And also there is tenderness over the dorsum of first ray present, and there is no tenderness over the sacroiliac joints. There is no pelvic compression. Pelvic compression and distraction tests are negative. I could not perform other sacroiliac joint tests, and the lumbar flexion is normal with modified
test
Scobus
is not
test.
possible. Sacroiliac test.
Sir, pelvic compression test and distraction tests are negative.
Is there a tenderness on the sacroiliac
No,
joint?
sir, negative.
Okay.
There is lumbar flexion is normal with modified confirmed by modified Scobus test, and there is reduced chest expansion, restricted chest expansion.
How much? And where did you measure it?
Sir, at the level of nipples, it is 1.5 centimeters. The excursion is 1.5 centimeters.
Okay. Other movements, spine.
Other spine
cervical
movements are
spine.
within normal limits.
Okay. Now, what is the diagnosis now?
It is a bilateral hip arthritis secondary to inflammatory arthropathy, most probably due to ankylosing spondylitis with nil neurovascular deficit in a 28-year electrician presently currently presenting with inability to walk unassisted, sit cross-legged and squat.
First pain. Currently disabled with pain and
Pain.
then inability.
So now, what would you like to do?
I would like to do an X-ray of bilateral hips, pelvis with bilateral hips, and lateral hip X-rays.
Would you like to do SI joint, sacroiliac joint and spine X-rays
Yes,
also?
yes, sir. With sacroiliac joints and spine X-rays also.
These are the X-rays. Describe the hip X-rays.
Anteroposterior view of hip X-ray with showing lower lumbar spines with pelvis and both hips. With there can be acetabular sclerosis and lytic areas.
Acetabular sclerosis.
There is acetabular rim sclerosis and femoral head sclerosis and lytic areas with concentric reduction of the joint space on both sides. With
Concentric reduction is more important. Axial pattern of migration, concentric reduction. Whereas in the avian, you will get superlateral sort of migration. Whereas axial pattern of migration goes more in favor of inflammatory etiology.
Good. If the X-ray has been
Why
not
is that
been
so?
put properly.
Why is
always
it
put
concentric reduction
Concentric
in
reduction
RE
in
and
the inflammatory.
in inflammatory pathology,
Why is it axial pattern of migration or central pattern of migration?
You know, you don't know.
Yes, anybody? Can anybody answer? Yes. Yes, so in the avian, it is antero-superolateral sectoral involvement, whereas it is now generalized involvement because of pannus in the rheumatoid, or other inflammatory also, it is a synovitis and synovial affection, which is generalized. So the pattern is more axial pattern, crystal induced, infective, the inflammatory, ankylosing, RA, the pattern is central pattern of migration, whereas it is here the superolateral pattern of migration in avian. No.
Also the sacroiliac joints it's not appears to be normal, so I will
Normal. SI joint is normal.
there is an
Are you
erosion
sure?
on the erosion
SI joint are which type of joints? Can you tell us? Huh? Which type of joints are SI joint? Yes.
understand.
Synovial joint. Okay. Yeah. So ankylosing spondylitis affects which joint?
The synovial joint.
Synovial joints. Synovitis and enthesitis. So inferior portion. What are Rome's criteria and New York's criteria?
Modified New York criteria is a definitive diagnosis of sacroiliitis. Bilaterally, it is more than or equal to grade 2, or unilateral sacroiliitis of grade 3 or 4, with a clinical criteria of stiffness, which is lasting for more than 3 months, which is lasting for more than 30 minutes, with reduced chest expansion, restricted chest expansion of less than 2.5 centimeter, and restricted lumbar flexion, which is confirmed by the modified Scobus.
What other investigation would you like to do?
I would like to do a MRI sacroiliac
Why
joint
do you
to
want
confirm
MRI? MRI, what will you see?
the sacroiliac joint involvement confirmed.
Involvement.
We don't have the MRI, sir.
Okay, fine.
And I will do hematological investigations to confirm the
Any
seronegativity,
other X-rays would you like to do?
to spine X-rays mainly,
Mm.
and also knee joint X-rays.
Spine, what do you see? What do you see? What is Romanov's sign? What is syndesmophyte? What is the difference between syndesmophyte and osteophyte?
The syndesmophyte is an ossification of the ligaments mainly, and osteophyte is a bony outgrowth seen in degenerative tissue.
Where the syndesmophyte appears, where the osteophyte will appear in the spine.
The syndesmophytes.
How do you differentiate? X-ray, how will you differentiate? Syndesmophyte, you said, is the ossification of which leg? Which leg?
Which ligament?
What is bamboo spine? Bamboo spine.
That is involvement of posterior longitudinal ligament with the ossification of the posterior longitudinal ligament, causing sclerosis of the complete spinal column.
So how is ALL or attached to each vertebra?
Where is it attached?
Sheet or it is
That will answer your question. That will answer syndesmophyte and osteophyte.
It is continuous layer.
does it have any attachment at segmental level?
It has a attachment.
Is
of-
bamboo outcome of syndesmophyte?
No, sir. No, sir. This is mainly the ossification of posterior longitudinal ligament and.
What is the earliest sign that you will see in the spine of the ankylosing spondylitis? Earliest sign.
Anderson's lesion.
What is that? Earliest sign.
Early,
Anderson is the earliest sign.
the erosion,
Squaring of
Squaring
the
of
vertebra.
Osteophyte is a sign of what?
degenerative
So what
instability.
what is body trying to do?
To increase the surface area of the joint so that the stress at a single point is reduced.
Prevent abnormal motion.
Prevent abnormal.
So osteophyte will grow. How will it grow?
Towards
They try to fuse.
yes, towards the bone.
So it will go towards the space, this space. While syndesmophyte is growing away because it's an ossification. It's not a stability provider. It will grow away like a cactus.
Sir,
What would you like to do for this? Any other?
I would like to confirm the diagnosis
Why?
with hematological investigation.
Hematology will confirm the diagnosis.
With an MRI, I will
Which-
confirm the diagnosis and also I'll do.
MRI will show increased intensity changes in the in and around hip joint. So how will you confirm?
There are also features of enthesitis. So there is high disease activity, suggestive of disease, high disease activity. I'll start the patient on DMARDS.
DMARDS is given for seronegative spondyloarthropathy. What? Which DMARD given? Disease modifying is for rheumatoid arthritis, no? Are they prescribed
anti-TNF alpha drugs.
directly? For the ankylosing spondylitis, you would start. Any other investigation?
for central joint affections, axial skeleton, there is no treatment. For peripheral skeleton, peripheral joints, DMARD is to certain extent act in ankylosing.
What is HLA between this one?
That's a gene located in the MHC2
Where is it located?
MHC2 complex.
Where? Which
Mohan,
which
he wants
chromosome?
to give you more marks.
Which chromosome it is? Anybody? Short arm of the sixth chromosome. Okay. What will you do for this?
Total hip arthroplasty.
Total hip ortho. What are the complications do you anticipate? Problems do you anticipate? Difficulties, problems, and complications?
Sir, mainly to insert an acetabular cup.
Enumerate, no?
Uh,
Enumerate the possible complications of performing total hip orthoplasty in this patient.
Because
Because you have to consult, no? Pre-op, you have to take a consent, no? You have to discuss with this. These are the possible complications.
Before that, before surgery, anesthesia.
it is very difficult to give.
For anesthetist, would you like to give something, do something for fitness?
Yes, sir.
What will you like to do?
Because the disease activity, they want to check the disease activity, ESR, CRP levels.
Disease activity is there. Next, anything else you would like? Would you like to?
What
Yeah,
anesthesia will they give? They'll give either spinal or they'll give general.
General.
Is there a problem with spinal anesthesia in this patient?
Yes, sir.
What?
There will
There will
There
be
will be
if you have
different-
ossification of the
ossification.
ligaments, you may not
There
get.
will be-
Is there a problem with general?
Yes, sir. Because there is a reduced. There may be reduced lung volume.
Ladies?
More
Lung-
than that,
lung
can
volume.
intubation
Neck
is easy
position-
if
neck
his neck
positioning would be
positioning
difficult.
not possible?
Neck positioning,
So you want an X-ray of his neck. You
cervical
want to
spine.
do a PFT because you want to know how good his lung capacity is
capacity.
before you do this. So these things before you jump straight. Second is the positioning.
Yes.
Sir can take your topic with that.
So all these are the basic things. Okay.
You must know everything about ankylosing spondylitis, about what are the, anticipated problems during surgery, before surgery, all these things. Because once you have crossed the clinical examination, they will ask you about this. During surgery also, not to total hip replacement only is not the answer. What are the problems expected? Even if it's ankylosing spondylitis, bones are osteoporotic, the possibility of fracture, all these things.
Periprosthetic
you must know.
fracture, dislocation may not be possible. Positioning, acetabular cup positioning, if the spine is fused.
He had, I think, knee deformities both sides, no?
There is no knee deformity.
Knee deformity was not there.
Was
It is secondary to the hip
Secondary.
position.
Subtoroid and ankle? I suspect so. Foot, you examined his foot?
Foot had a
Yes, sir.
mid tarsal synovitis. Yet synovitis.
I think we should proceed with the next case now. We are really running late on
Okay.
schedule. We
Finally,
just have one
yeah.
single question from one of the doctors there.
Please.
Can we just pass him the mic? Meanwhile, we invite Dr. Aman for the next presentation. Bharat, you can hand over the mic.
Yes, please.
Mic. Just a second.
So in a bilateral hip AVN case, as sir said, in a windswept deformity case, we can't do a pelvic squaring. But if there's a bilateral adduction deformity or an abduction deformity, can we do a squaring? And if yes, which ASI has to be taken as reference?
No, we cannot, because if it's a fixed deformity, we cannot, because we can't square the pelvis. No?
Okay,
We
so
won't be able to square the pelvis.
yes,
you know.
so
And one-
windswept as well as a bilateral adduction.
Yeah, because
deformity.
Bilateral adduction, your legs are like this crossed over, no? So there's no question. No. You'll probably have a pelvis which is square, yeah.
if the pelvis is already square, then it's different story. Pelvis is not.
So
pelvis is
in these
square.
patients, you will not have these patients ambulant because you cannot compensate for a bilateral adduction deformity to get your legs straight to walk. So these are somebody who has cerebral palsy or spastic paraplegia who are scissored.
Even for a bilateral abduction deformity,
So bilateral abduction means you have a wide, unless he can get his legs together, he's not going to be able to walk. So it's unlikely to have that.
Bilateral adduction is common in ankle.
Hmm.
They can't clean this, so they are always walking very small waist.
so we
See,
can't comment.
Just
on
to keep it simple, you have to see whether you can square the pelvis or not. Two prerequisites are to be met for measuring for the true limb lengths. True limb lengths, you have to square the pelvis and keep both the limbs in identical position. So that may be out. Then for measurement of the deformities, you have to square the pelvis, right? So if you are not able to square the pelvis, you may not be able to measure the pelvis. But then another thing is the pelvis is already square, and then there are deformities. Then it is straightforward. Then you should be able to measure with the reference of the midline of the vertical plane of the body.
Thank you.
No, the bilateral definitely not, because bilateral definitely you cannot do it. Right? It is Kotaris angle is only for the unilateral piece.
The bilateral adduction or abduction deformity, that the spine position can be square the pelvis.
Yes.
Generally, if it is a bilateral adduction deformity, they can't be more than 15 degrees. So nobody will scissor like this and walk like this. So usually they are very small deformities and pelvis may
That
be
type
more.
of bilateral deformity exists only in cerebral palsy. The way you people are describing is purely hypothetical. I don't think ankylosing will.
It is-
this.
It is usually
Because
if you
that's not a
have
position of
combination.
comfort. That's not a position of comfort.
Usually it is combination, like one side you have adduction, other side you have abduction. So like in this earlier patient.
Okay. I think we expedited before, and Dr. Sunil wants to. Sunil Shane.
Yeah. So we would like to felicitate Dr.
Take your question. One second.
Dr. Sunil Shahane sir
Just
with a token of
second.
appreciation.